Welcome everyone to the second session of the Scottish Pain Research Network ASM. We've got 4 speakers for this session. It will take us up to 1 o'clock. So without any further delay, I'd like to introduce Harry Herbert. He's a postdoctoral researcher in the University of Dundee Chronic Pain Research Group, and that's within the Division of Population Health and Genomics. He's going to talk to us today about assessing the impact of the SIGN 136 guideline, which is the management of chronic pain in primary care guideline, and he's going to look specifically on the opioid prescribing rates in Scottish primary care and describe some of the work that he's been doing. Over to you, Harry.
Thank you very much, Paul. Just share my slides. Can I just check, Paul, that you can see that?
Yes, I can.
Brilliant. Thank you, Paul, and thank you to the organising committee for inviting me today and giving me the opportunity to talk about this study. As I'm sure most of you are aware, opioids are commonly used to treat chronic pain. However, their long-term use is associated with various harms, and prescribing rates have been increasing worldwide, particularly in the USA, which has given rise to the opioid epidemic. Research suggests a similar situation could be happening here in Scotland, with an 18-fold increase identified in prescribing of strong opioids in Tayside from 1995 to 2010. Around 2008, a gap was identified in the clinical management of chronic pain, and subsequently the Scottish Intercollegiate Guideline Network published SIGN 136 Management of Chronic Pain in December 2013. This included evidence-based recommendations on safe and effective opioid prescribing, with the goal of reducing unnecessary and potentially harmful opioid prescribing, aimed mainly at non-specialist settings. Subsequent research identified a 10-fold increase in strong opioid prescribing rates in the 10 years leading up to SIGN 136 publication. In contrast, gabapentinoids, which are first-line medications for neuropathic pain, received relatively little research and media coverage at the time, and subsequently less focused attention in SIGN 136. However, recent evidence has suggested that gabapentinoids are increasingly being used as substances of abuse. Despite being one of NHS Scotland's key national therapeutic indicators, to the best of our knowledge, no studies have formally investigated the potential impact of SIGN 136 on opioid prescribing rates. Therefore, this study aimed to examine opioid prescribing rates in Scotland and analyse their association with SIGN 136. A second aim was to compare opioid prescribing rates with gabapentinoid prescribing rates. The hypothesis is that SIGN 136 is associated with a reduction in opioid prescribing trend. So for this study, we used an interrupted time series approach. This technique tracks an outcome measure longitudinally over a certain period of time, both before and after an event, and assesses the event's effects by measuring the change in level and the change in trend after the event. The absolute or relative change in the outcome is also calculated at a particular time point by comparing the expected outcome had the pre-intervention trend continued, which is also known as the counterfactual, to the observed outcome. This concept can be extended to include a second time series, which is usually one that hasn't been subjected to the event, which can act as a control. This allows investigators to adjust for any potential confounders that might have an effect on the outcome. As well as the 4 single group parameters for the control group, this analysis also calculates 4 additional parameters between the case and control series: the difference in the intercepts, the difference in the pre-intervention trends, the difference in the change in levels, and the difference in the change in trends. The prescribing data on opioids and gabapentinoids were obtained through a bespoke request to Public Health Scotland, who hold the data via the Prescribing Information System. Aggregated data were obtained by quarter for Scotland from Q1 2005 to Q2 2020. The dataset includes all items issued within primary care in Scotland, regardless of prescriber type, and subsequently dispensed in the community. It does not include any items issued but not subsequently submitted for dispensing or claimed for by the dispenser. It also excludes private and hospital-based prescriptions. As GPs are estimated to account for approximately 95% of community prescribing, this dataset is a comprehensive representation of opioid and gabapentinoid prescribing in Scotland. A list of the drugs included in the data extract are shown in the table on the right, and these include single opioids found in Chapter 4.7.2 of the BNF and opioid-containing combinations. For the statistical analysis, linear regression was used, including time, intervention status, and the interaction of the intervention status and time as covariates for the single group analysis. In addition to these, time series status was added to the model for the controlled analysis, along with interaction terms with the other covariates. The models were checked for autocorrelation using the Durbin-Watson test. A Durbin-Watson test statistic range of 1.5 to 2.5 was used to indicate an acceptable level of autocorrelation, and models outside this range were corrected by calculating New West standard errors. The intervention was defined as the original publication of SIME 136 Q4 2013, meaning that we had 36 data points before and 26 data points after the intervention. The outcome was the number of prescription items per thousand population, with opioids being compared to gabapentinoids. In addition to this, a stratified analysis was conducted according to opioid strength. Compound drugs were classified according to their parent opioid, with codeine, dihydrocodeine, and metazanol classified as weak opioids, and everything else classified as strong. And because of the uncertainty around the status of tramadol, this was excluded from the stratified analysis. The effect of the intervention was summarized by way of the relative change in the outcome at the end of the analysis period in Q2 2020, expressed as a percentage. The 95% confidence intervals for the effect sizes were calculated from model estimates using bootstrapping techniques. So this slide presents some descriptive statistics from the analysis. A combined total of over 91 million opioid prescription items and over 12 million gabapentinoid items were dispensed in Scotland during the study period. Cocodamol and tramadol were the two drugs with the highest number of items and had more items prescribed than the other 26 drugs combined. In the results of the single group interrupted time series analysis, as shown in Table 1, there was a significant positive trend in opioid prescribing rates of plus 2.19 items per thousand population per quarter up to Q4 2013, followed by no significant change in level, but a significant negative change in trend of minus 2.82 items per thousand population per quarter associated with SIME 136 publication. This led to a negative trend in opioid prescribing rates of 0.64 items per thousand population per quarter after SIME 136 publication up to Q2 2020. At the end of the study period in Q2 2020, the observed prescribing rate was 20.67% lower than the expected rate at the same time point had the pre-publication trend continued. In contrast, as shown in Table 2, there was a significant positive trend in gabapentinoid prescribing rates of plus 0.88 items per thousand population per quarter up to Q4 2013, followed by a significant positive change in level of 8.00 items per thousand population and a significant positive change in trend of 0.27 items per thousand population per quarter associated with SIME 136 publication. When opioid prescribing rates were adjusted for gabapentinoid prescribing rates in the controlled analysis, there was a significant negative change in trend of minus 3.09 items per thousand population per quarter associated with SIME 136 publication. There was also a significant negative change in level of minus 9.09 items per thousand population associated with SIME 136. This translates into an adjusted relative change of minus 24.85% at Q2 2020, and this is compared to minus 20.67% in the single analysis. In the stratified analysis by opioid strength, there were significant positive trends in both weak and strong opioid prescribing rates up to Q4 2013, followed by no significant changes in level, but significant negative changes in trend associated with SIME 136 publication. In weak opioids, this led to a negative trend in prescribing rates of minus 0.35 items per thousand population per quarter after SIME 136 publication up to Q2 2020, whereas in strong opioids, a positive trend in prescribing rates was maintained of 0.27 items per 1,000 population per quarter. Nevertheless, the relative change in prescribing rate at quarter 2 2020 was minus 12.91% for weak opioids and minus 17.49% for strong opioids. And when comparing weak and strong opioids in the controlled analysis, there was a significant difference in the change in trend associated with SIGN 136 publication of minus 0.46 items per 1,000 population per quarter. So to conclude, publication of SIGN 136 is associated with a statistically significant change in opioid prescribing trend in Scotland. As a result of this change in trend, prescribing rates have been falling since 2014 and are approximately 20% lower in quarter 2 2020 than they would have been had the pre-publication trend continued. This association with SIGN 136 publication was maintained when controlling for gabapentinide prescribing rates, which themselves were associated with a significant increase in prescribing trend in relation to SIGN 136 publication. A partial explanation for this could be that opioids are being swapped with gabapentinoids. On stratifying the opioid data based on strength, it appears that most of the change in trend is being driven by weak opioid rates, which have been falling since quarter 4 2013, whereas strong opioid prescribing rates are continuing to rise, albeit less than they were before SIGN 136 publication. As SIGN 136 has been influential in driving subsequent publications, including the Scottish National Prescribing Strategy for Chronic Pain, the findings of this study suggests that changes in clinical policy are having a positive impact on prescribing practices in Scotland. However, we cannot rule out other possible explanations for the changes in opioid prescribing trends, and these require further investigation. In addition to this, future studies should investigate whether other opioid-related outcomes, including misuse, abuse, and death rates, have shown similar changes since SIGN 136 publication. So I'd like to thank the people who have worked on this study, Professor Leslie Colvin, Professor Blair Smith, and Dr. Daniel Morales from the University of Dundee, and Dr. Nicola Torrance from Robert Gordon University. And finally, I'd like to thank Public Health Scotland for supplying the data. I'll now hand back over to Paul, and I'm happy to take any questions.
Thank you very much, Harry. That's it's heartening to see that the guidelines have some impact, especially for those that spend a bit of time working on them. To see that they actually make a difference is useful. There's a couple of questions coming in. We've got a couple of minutes, if you wouldn't mind. The first is from David Walsh, who's saying that, or rather asking, is he interpreting correctly that strong opioids and its use continues to increase after SIGN, and is that because tramadol is being used less?
Yes. So. I can see the potential confusion there. Yeah. So there is in both strong and weak opioids, there is a negative change in trend compared to the baseline trend. But in strong opioids, we're seeing that there is a continuation of the trend post-intervention, whereas in weak opioids, that is now falling. And there is a bit of a debate over whether tramadol should be put in the weak kind of group and whether it should be put in the strong group. I actually did another analysis including tramadol in the weak group because in SIGN 136, which is what this kind of study relates to, it is actually classified as a weak opioid, and there's an even stronger kind of change in the trend with the weak opioids. So yes, I think the kind of the change in trend is kind of largely to do with tramadol. Okay. And it's kind of linked mainly with the weak opioids.
Okay, thank you very much. So we've run out of time for any more, but I think that might have answered the next question that was asked by Debbie Stephen in any case. But if not, I'm sure she can communicate with you directly.